Hi, Elizabeth. Elizabeth.
Recurrence of this unfortunate and
Eliza, hi.
Oh, hi.
Oh, hi, yes.
Hello, Emily. How are you?
Poa sana. Uko poa?
Can you hear me? Nashukuru niko mwema na wewe.
Niko poa. So I have made you and Dr. Christine presenters.
Okay.
Yeah. Can you try to see if you can share?
Okay, let me try. Hi, Dr. Marete. Okay, let me try to share. And can you see my screen? Oh, let me do the slideshow. Can you see my screen?
Nimepata.
Iko sawa?
Bado si okay, from where I am I can't see it yet. Yeah.
Okay, so let me exit again and try once more. So share. Okay, let me see. That was screen. Choose what you want to share. Screen, right? Oh my gosh. What am I sharing? Screen, window, or tab? Emily?
Can share your window.
Because let me try window because looks like okay, I think I'm in now. Let me try again. Share. Nikikosa niite SOS. Can you see me? Bado ionekani?
Okay, I don't know if Dr. Marite you can confirm kunaona, maybe niko na internet shida mahali niko, but I can't see from where I am.
You can see from where you are. Okay, let me just try again. Because you said I share the window, right? Yeah, because I can see my on the window. I've already opened the presentation, right?
Yes.
So I'm supposed to. Oh my gosh, to share. Ebu ita John, nitie John akuja nisaidie. I don't understand what's going on. Share. Because it's telling me start sharing, which I'm doing. I'm wondering why it's not moving. Wacha nipate SOS kwa awa majenzi.
Okay.
Inashotelea. Okay, just a few minutes you'll be here.
Okay.
Just to confirm, can you guys hear me? Dr. Marete here.
Yes, we can.
Yes, we can.
Dr. Marete, we can. I don't know why
So
I'm
let
not
me
able to share. I'm trying, but it's not showing on the other side. I'm trying to share the window. So here, this is my, oh, where has it disappeared to? Because it was open, right? Tufunge hizo zote. Ni exit. Because maybe zinaleta shida sijui kwa nini. Ndio ya. Can we exit from all these bits? Because then the hello.
I can hear you.
Can you see my screen?
No.
Okay, just a minute.
Elisa, you can also share with me. I can project for you in case of any challenge.
I'll do that right shortly. So it's this one, right? It's this one. So let's see, share.
It's sharing.
It's sharing. So on our side, it's sharing. So I'm wondering if I'm going to have a challenge, then I'll share with you, Emily, so that you can share for
that's
me.
fine.
You can't see me, Bado.
But we can't.
Oh boy. They can't see me. Okay. So let me share it with you, Emily, right away.
Okay.
Sorry about that hitch. To Emily. So Emily, Emily.
Yes.
So I don't know which signal will I be giving you for you to move to the next slide.
You can just say move to the next slide.
Okay, I can
So
tell
I'll
you
try
that.
to follow. I'm settled somewhere. I'll follow.
Okay, so I've shared with you. Angalia
Okay.
kama utaiona. Thank you.
Elizabeth, you can see it, right?
No, not yet.
Yes, I can also see it.
You can see it. I might have an issue on my side then. So,
actually, Elizabeth, you can just present from your, what did I want to say? You can be working on your documents, like present with what you have, then I'll be just following you as you present.
Okay. So, but you'll be the one to share the slides, right?
We lost Emily.
Emily.
I'm saying
Mhm.
Elizabeth can use her presentation to read through. Then from my end, I'll just be following her and going to the next page.
Okay. Iko sawa. Oh. Although I can't see the screen, bado. I'm not seeing the screen from my end.
You can use your laptop and then she just moves the screen for you.
Okay,
She moves
sawa
the
sawa.
slides for you. You just present
Okay.
on your end, then Emily moves as you go.
Okay, sawa sawa. Okay, thank you. That's noted. Thanks.
Emily, what will be quorum? Like, when can we begin? At what minimum number?
We can give them the next 4 minutes, then we'll just start.
Mhm.
Okay.
Yeah.
Hello and good evening, everyone. Please confirm that you can hear me, Dr. Esther.
We can hear.
Okay, good evening again. My name is Dr. Marete. I'm going to be the moderator for today's presentation, which is a non-pharmacological management of pain in children with palliative care needs. So welcome to the presentation. I'm going to go ahead and introduce our speaker for the evening. So our speaker today is Elizabeth Kabuthi. Elizabeth Kabuthi holds a Bachelor of Arts in Sociology and is currently pursuing a Master's in Sociology. She serves as a Senior Medical Social Worker and Certified Child Life Specialist. She's also the Program Coordinator for the Sally Test Child Life Program at the Moi Teaching and Referral Hospital, Ampad. Elizabeth has among her notable professional achievements, she was a scholarship winner for the Association of Child Life Specialists Annual Conference in 2014 in New Orleans, USA. She's also the pioneer child life specialist in Kenya and one of the first in Africa. Additionally, she's the president of the Child Life Association of Kenya and a member of the African ECHO Steering Committee for the past 3 years. Elizabeth is also a board member and grief instructor for the Sibling Grief Support at the Tears Foundation Kenya chapter. She has presented at numerous national and international platforms and has published a paper in the Association of Child Life Specialists Bulletin on the challenges around certification in Kenya. Elizabeth has a lot of enthusiasm for alleviating the suffering of children with cancer and other life-limiting illnesses and their families, with a focus on improving their quality of life. She's committed to mentoring other healthcare professionals who are passionate about the psychosocial care and well-being of children and their families. Her personal interests include providing sibling support for children with life-limiting illnesses, training healthcare professionals in child life and the best practices for children in healthcare, and serving as a sign language interpreter in the healthcare setting to enable families with hearing impairments to access healthcare services, including palliative care. So I'm a very much decorated presenter for the evening. Welcome and everybody enjoy. Before we even start, remember you can put your questions in the Q&A that we can address them at the end of the presentation. We'll also have a session at the end to address some of the questions. So enjoy and let's see your questions at the end. Thank you.
Hello, everyone, and thank you, Dr. Marete, for that kind introduction. I feel honored to be the speaker for this day, and I hope we are here to learn from each other. I'm looking forward to also learn from you all. So feel very welcome as I get into the gist of the session today. So we are going to begin with the introduction of what non-pharmacological interventions are, and allow me to use the abbreviation NPI as we are going forward. So NPIs means the management of pain without medications. It's a really straightforward definition. And for this case, we are going to think about ways in which we can alter thoughts and focus concentration to better manage and reduce pain for children with palliative care needs. We also consider the fact that children learn best through the 5 common senses. So they will be listening, they will be observing, they will be tasting, they will be hearing, and so many other ways in which children learn. They also learn best using visual aids. And so in the presentation that is ahead of you, I have used a lot of visual aids so that we can all have an understanding into what we are discussing today. So an overview of children's palliative care, we all know that we are focusing on improving the quality of life, just adding life into the days of these wonderful children that we work with. And when you look at my sub-theme, I've discussed about enhancing comfort. When we think of comfort therapy, think about what families can do. And so for NPIs, we are not only focusing on the child, but also focusing on the family as well. The family remains a constant in the life of the child who is our patient. And so we are here to train the family members on the very many ways in which they can offer support and comfort to their children through non-pharmacological interventions. So what is the importance of NPIs in pain management? We can categorize NPIs in 4 ways. Number 1 is behavioral. How does a child behave? What are we supposed to do to alter their behavior in order to alleviate pain and suffering? We also look at cognitive aspect. We also look at the restorative aspect of the technique that we are going to teach and the complementary therapies that we are also going to teach to the children and their families. Remember that the purpose and goal of NPIs is to decrease fear, distress, and anxiety. We are not only talking about NPIs being the main thing, but we utilize them alongside pharmacological pain intervention methods. So for children, they love having a sense of control. But when they are admitted in a hospital with a life-limiting illness, that sense of control disappears. For example, a child is supposed to eat at a particular time when they are in the hospital. They're supposed to take medications at a particular time. They're supposed to sleep whenever they are receiving medication. And so a child will feel their sense of control has been withdrawn and they become very anxious. They can have increased fear. They don't understand why suddenly the environment for them has changed. So it is our responsibility to ensure that we still maintain that sense of control in children. It is important to offer valuable alternatives and also remembering that we are complementing different aspects that will still promote holistic health and minimize side effects. We are also here to empower individuals who are the family and also the child, and especially the child who is the adolescent. They are also able to manage their well-being on their own selves. Remember also that it is complementary to pharmacological, I've said that, and we are also looking at cost effectiveness of NPIs. In some situations, you will find that families are not able to afford pain medication. So the NPIs will come in handy in that situation where the family is not able to afford pain medication, or maybe they have been discharged from the hospital with pain medications, but on going home, the pain meds are finished and the child is still in pain. So NPIs will come in handy for these families to use them whenever their child is in pain. NPIs are also tailored to the unique needs of a child. If a child is undergoing spiritual pain, then we focus on spirituality. If a child is undergoing any kind of pain, be it neuropathy, any kind of pain, then we are going to tailor it to that specific child. So the next slide is talking about types of pain experienced by children in palliative care. Each type is unique, and each type of pain requires a comprehensive assessment. And the multidisciplinary teams, including pediatric palliative care specialists, nurses, psychologists, pain management experts, child life specialists, all of these different cadres work together, collaborate to ensure that we develop individualized care plans for each child meeting their own unique needs. So what are some of the types of pain for children with palliative care needs? So we are going to talk about physical pain, spiritual pain, procedural pain, which is a one-off, symptom-related pain, psychological and emotional pain, complex pain syndromes, breakthrough pain, and visceral pain. All these pains is important for a healthcare provider to understand the kind of pain that the child is experiencing so that we are able to identify the particular intervention that is going to work best with that child. So what are some of the challenges of assessing pain in children? In the last session by Dr. Nafula, she spoke at length about pharmacological pain management methods. And we all agree that assessing pain in children is quite difficult. And the reason is that children are not able to adequately express what they are going through. And this is because they have a limited vocabulary to name their feelings, especially more so in the preverbal and developmentally disabled child. Many children who are infants are not able to speak about their pain. Maybe you can observe through behavior a child who is crying all the time, a child who is unable to feed well, a child who is not sleeping at all, a child who is not playing. They are expressing their level of pain behaviorally. So according to McCaffrey 1989, he discussed about pain being whatever the person says it is and existing whenever the experiencing person saying it does. In many situations in our hospitals, you will come across different people who will be fast enough to discuss and tell children it is not painful. Iyo sio chungu sana. We've had so many people tell children that when I want to do a cannula insertion, maybe the clinical officer or the healthcare personnel will tell the child, usilie, si uchungu. But today we are learning that pain is whatever the experiencing person, or in this case, the child says it is, and it is existing whenever the experiencing child says it does. So assessing pain become quite a challenge to children. Unlike in adults, adults are able to explain what they are going through. But for children, because of communicative differences, cognitive differences, developmentally, we have a challenge in assessing pain in a child. However, by pain assessment, which is a broad concept involving clinical judgment based on observation of the time, significance, and context of the individual's pain experience, we are better able to handle pain in children. So there are 3 ways in which we can assess pain in children with palliative care needs. And number 1 is self-report. This is the golden standard. What does the child say? How is the child behaving? If they are verbal, what are they saying about their pain? At what time is the pain more? At what particular point in their body are they experiencing that pain? Behaviorally, how is the child behaving? Are they able to feed? Are they able to sleep well? Are they verbal? Are they verbalizing their feelings? Are they able to do what pertains to a child as they grow up? And finally, physiologically, what are the clinical observations that let us know that actually a child is experiencing pain? So what are the goals of NPIs? We discussed previously, and I talked about minimizing fear and distress. Many children are afraid of hospital-based procedures because they have a misconception that all procedures cause pain in their bodies. So we can be able to make pain more tolerable to children. We are not saying that we are going to remove the pain in totality, but we are going to make the pain more tolerable for children so that they are able to play normally, they are able to feed normally, they can even experience hours of sleep and disturbed sleep even if they have an amount of pain that they are experiencing. We want to also give this child a sense of control over the situation and their behavior. We also want to teach and enhance coping strategies, and we also want to instruct parents in techniques to assist their child. We've discussed about the importance of family-centered care. This child, especially the very young ones, cannot do the technique on themselves, but they will require a family member to be there to learn, to get instructed, and to perform the NPI on their children. So family-centered care approach is really important, and we are all called to remember that the family remains the constant in a child's life. Whether the child is in the hospital or at home, parental presence is key. Whenever we are doing procedures, let that parental presence be felt. It could be a parent from home who is a caregiver. It could be a grandmother. It could be a sibling. But that is a person who is closest and who is most significant, who has the knowledge of their child at that particular moment. So if we are able to ensure that parental presence is upheld, and we also make sure that the caregivers are less stressed, because when a parent is stressed, it rubs off on the child. And so we are called to work first and foremost with the parents or the caregivers, so that they can understand the non-pharmacological intervention that we are going to do with the child. They become calm themselves, they are less anxious, and then we can work with the same intervention on a particular child. So number one NPI that we are going to learn this evening is positions for comfort, also termed as comfort therapy. Parents are supposed to be comforters of their children and not restrainers. In some situations, we find parents being told to pin down a child during an invasive procedure. What happens to children is that it creates enmity between the parents and the child. The parent is not supposed to forcefully pin down their children during a procedure. Let the parent hold their child in a comfortable, safe way. Let the parent be the safe haven for their child, even if they are going through a procedure that requires a particular position of comfort. So there are different types of positions for comfort that we utilize at the hospital. The number one is newborn or infant swaddle, where we help parents to learn on how to swaddle their children by ensuring that the hands are put downwards along the body of the child to reduce the motor reflex in infants. This way, children are able to remain calm whenever a procedure is going on. Back to chest, chest to chest, side sit position, and the frog position. All these positions utilize the parent as the comforter to the child. The parent is also able to ensure that the part of the body the doctor wants to access is open and free for that particular procedure, while at the same time offering comfort to the child. They can sing to the child, they can speak to the child and reassure the child. They can utilize a familiar tune that is known to the child, especially the very young ones. And therefore, the parent will become a source of comfort to their child during these procedures. What are some of the benefits of comfort therapy? They can keep the child from having to be on their back. Remember, being on their back presents a very vulnerable position for a child, and they become very anxious. When the children are lying on their backs and they are looking up at the medical team surrounding the bed, these children look at us as if we are giants, and they feel quite vulnerable. So it is important that if this particular position, this particular procedure to be on their back, then let the child lay their back on the laps of the parent so that the child can look into the face of mommy or daddy. We have said that putting this child on their backs will help allay anxiety and fear. A comfort position also ensures that the child stays still during the procedure and reduces pain, because when the mother or father is speaking to their child in a reassuring voice or singing a familiar tune, the child is distracted from what is going on. However, we also have very vigilant children who want to experience any procedure that is going on. But when the family is utilizing positions of comfort, then the mother or father is able to ensure that the procedure can go smoothly while reducing pain in the child. So the next slide is speaking about psychosocial interventions, and these are crucial to address emotional, social, and psychological well-being during a challenging and sensitive time. These interventions are designed to still offer support, alleviate distress and pain, and enhance coping mechanism for both the child and their family. Play therapy is one of the psychosocial interventions that we utilize. We discuss play as the cardinal tenet upon which child life profession is anchored. Play is the vehicle for communication in children. It is a soil in which children thrive. Through play, issues that can affect a child, including trauma, anxiety, depression, grief and loss, behavioral challenges, family conflicts, and developmental delays can all be sorted by play therapy. It offers developmentally appropriate and effective approach to promoting emotional healing, growth, and well-being in children. A child who is not playing means that they are going through a painful process. So it is important to ensure that no matter how much pain a child is going through, we can offer them short intervals of play opportunities. A childlike specialist can play on behalf of a child. We can offer bedside activities just to ensure that the child engages in a play session throughout the day. Gottfried Benn, a very well-renowned philosopher, said that whoever wants to understand much must play much. So if we want to understand children, let's remember to play as much as possible with them in order to alleviate pain and suffering. So some of the benefits of play therapy are emotional expression. You can observe the way a child is playing. They can be able to express their emotions through an activity. A child who is going through a very difficult emotion can be given an activity where they can act out, they can hit out, and they can dispense negative energy. It also gives them an opportunity to problem solve. They become self-aware and they gain some insight. It is also a means of which they can learn communication skills. They are able to express themselves better. If a procedure is painful, a child is able to express and tell the medical team, this is what I'm feeling and this is what I'm going through. It also offers opportunities for emotional regulation. Teaching children techniques to manage and regulate their emotions effectively is important, especially for children with palliative care needs. We teach them deep breathing, relaxation, and mindfulness exercises. Finally, social skills. Important to improve social skills, peer interactions, because in play, a child is able to understand another child better. They are able to share their joys, their fears during palliative care, and they're also able to take turns and resolve conflicts peacefully. So this slide shows examples of the play activities that we offer at MTRH. On the slide on the left, we can see these are adolescent or teenage children in the oncology unit. They love biking. Even when a child is quite sick in the ward, they will always come down to the play area to ensure that they have an opportunity to ride the bike or even sit by the grass and observe their peers ride on the bikes. On the right, these are children blowing bubbles, you can see, and we all know that bubbles are a favorite for most children and it helps them with relaxation activities. Number 2, psychosocial intervention is music therapy. Music ignites our world. It doesn't matter if you're understanding the words, the lyrics, music will still ignite. We can all imagine the number of times we shake our bodies to a familiar tune or a very interesting tune that transforms our bodies, and we all want to dance to that music. The same thing happens to children with palliative care needs. So music therapy is a form of therapeutic intervention that utilizes music and musical activities to address physical, emotional, cognitive, and social needs of individuals, this time children. You can see on that picture, these are children who are on the wards. Some of them are still with us and some are not with us, enjoying a violin class, which they love so much. So what are the benefits of music therapy? Pain management is key. It has been shown through research that music therapy reduces pain perceptions. It can provide an non-pharmacological method of pain relief. It releases endorphins, which are the body's natural painkillers. For situations where we don't have music instruments, we can offer children a Bluetooth speaker or even use their phones to ensure that they can listen to music while they are lying in bed or even when they are going through a procedure in the hospital. It provides them an opportunity for emotional expression and also stress reduction. We have talked about the release of endorphins. This trigger of endorphins brings out the good hormones in all of us, and children are not left aside. And that beautiful feeling of music provides them with a natural painkiller for those moments when they are going through pain. It also promotes cognitive stimulation for the children who are declining, deteriorating. They are able to maintain cognitive ability and promote development cognitively. Also, social interaction. When children identify with a particular musician or when they love particular genre of music, they can have social interactions, especially for teenagers. They love particular genre. So they have, you know, that moment where all of them will want to dance to a particular song when it plays. And that social interaction is really crucial, especially in pain management. By harnessing the therapeutic power of music, it can improve quality of life, alleviate distress and pain, and promote overall well-being for these children and their families. On this slide, you can see the Zumba sessions that we have at the hospital. We offer Zumba sessions once a month, and in some months we can do it twice a month. It is a favorite for children and their caregivers. Zumba is a way that we can all exercise our bodies. If you have tension in your muscles, if the children are tense, this is a moment where by listening to music, we can shake our bodies and release negative sensations brought about by pain. Another psychosocial intervention is through art therapy. It is a form of psychotherapy. By utilizing creative processes, children are able to express their emotions in a very good way. That picture that I have shared, these are the children that we work with, and you can see them really happy holding the paintbrush and painting that picture. And you know, when they see the end product, it instills in them a feeling of accomplishment when they look at that picture. It gives them an you know, that aspect of accomplishment. I have managed to accomplish a task, and by doing this, they are able to exercise both fine and gross motor skills. We all know that muscles get depleted, especially for children who have life-limiting illness. They are staying for long in the hospitals. Many times they are on their beds and they are not doing much to exercise their muscles. So when we give them an opportunity to do art, to do crafts, to do music therapy, they can exercise both fine and motor skills, and they are able to win back their muscles. So in this slide, we are talking about the benefits of art therapy. So there is emotional expression. And I want you to look at the young girl who is holding her cheek. And she was emotionally expressing herself. She was going through a difficult time of her life. And in as much as she was in so much pain, she made sure that she came to the playroom even in her lowest moments. She made sure that she could access art materials to take to her bedside even in her low moments. She utilized play opportunities, art therapy opportunities, which provided her a safe space or harbor to internalize, to regulate her emotions even in her low moments. It did not matter what she was going through, but she felt safe to come to the playroom and hold her cheek and allow us all to get into her world and understand what she was going through. So art therapy is really key, especially in emotional expression for children with palliative care needs. So this is a display of what artwork is designed by the children you can see on this slide. They are happy displaying the work that they have achieved. Accomplishment is really important for children with palliative care needs. Another psychosocial intervention is mind-body interventions, and this is defined as each individual being unique and the cause of disease and the strategies for cure being unique to every child. Barton Goldbach and Group, 1993, discussed that chronic stress and lack of balance in one's life contribute to disease and illness, and therefore everyone has in their power different interventions that we can utilize to reduce pain, to ensure that we are able to cope well no matter what we are going through. The mind is the biggest organ in the body when it comes to pain management. And so the following 3 techniques can be used under mind-body interventions. That is relaxation technique, guided imagery, and breathing exercises. So what is guided imagery? It is most often used as a relaxation technique. It involves sitting on line quietly and imagining yourself in a favorite peaceful setting or engaging in a favorite activity. For children in this case, they use all their senses in their imagination to help relax the body and develop a sense of well-being. And for guided imagery to work, the following 3 processes have to go through by a child: image generation, image maintenance, image inspection, and finally, image transformation. Breathing and relaxation techniques. Usually during the fight or flight response, our hearts will begin to pound. And that is what happens when we tell a child they're supposed to go through a particular procedure, or when a child is going through a painful procedure. Their hearts begin pounding because all of us have a fight or flight response. It causes us to be hyper alert, and this hyper alertness causes adrenaline to increase, muscles tense, breathing becomes so fast, causing tight muscles, which eventually causes a lot of pain. And so for children to be able to allay this anxiety and to reduce the pain that they are going through, we must be able to make them breathe, and we must be able to make them relax their muscles. You can utilize an example as shown on this slide. Children can practice to blow bubbles. By blowing bubbles, it will make sure that the child inhales an adequate amount of air, which will make them blow that bubble. And you can see the beautiful smiles when they were able to form that beautiful bubble after releasing the air in their lungs. They are able to relax their muscles automatically. You can use an example of blowing imaginary birthday candles, or you can use a pinwheel or inexpensive balloons. Tell a child to blow into a balloon, and that way they are able to relax their muscles. So we're also going to look at integrative approaches. And integrative approaches to pain management involves combining conventional medical treatments with complementary and alternative therapies to address pain and improve overall well-being. And some of the approaches that are used globally are animal-assisted therapy, massage therapy, acupuncture, yoga. I know we don't use animal-assisted, but it is used in the West. What we do occasionally is massage therapy and yoga. So on this slide, we have children on their yoga mats doing a yoga session. And yoga is so good because it optimizes treatment outcomes by addressing pain from multiple angles. This is so important for children who are experiencing chronic or acute pain. It gives them an opportunity to listen deeply to the kind of pain, which part of the body is experiencing pain. They get into that particular part of their body. They experience mindfulness in the moment, in this particular moment. Where is my pain? They internalize the pain, and they work accordingly to alleviate that pain. Massage therapy. It offers numerous benefits that contribute to both physical health and emotional well-being. It can be a valuable component of holistic approach, and it can be used to promote relaxation, reduce pain, and support the body's natural healing process. So massage benefit has a lot. Massage therapy has lots of benefits. Remember that massage are simple, effective ways that are soothing. Think of yourself when somebody touches you, or when somebody pats your hand, or when somebody massages you, maybe after the end of a hard day's work. Your spouse or maybe a friend massages your neck. What is the feeling that goes through your body? There is so much healing. That is exactly what massage does to children. It can be able to target specific areas of tension or pain in a child's body. And that way, they are able to release the coils in their body. The tense muscles, the tense knots can be released by that act of massage. So in this slide, the child specialist is massaging a child and of course, instructing the parent on what to do when they are in the hospital, and also it can be done when the child is at home. So gardening in children's palliative care. We talk about therapeutic horticulture play, and gardening has become an increasingly important role in palliative care. Children with palliative care needs can utilize gardening, and this way it has a positive impact on the patient's well-being. When we encourage children to plant a legacy for their families by exercising adopt a tree concept, where a child is shown how to nurture. They go to the garden daily. They water that plant from the time it was a small seedling. They plant every week. There is growth. There is development. And that child is able to reflect on the passing of time and seasons. And they are able to reflect on their own lives about the time has passed and the time that is remaining, which they have. And in cases where the children pass away, then this family is given a particular tree that the child nurtured to take it home as a remembrance. You can see this slide. We are using nature to enhance well-being for the children. They are really excited when they see the beautiful flowers bloom. They see the flowers grow. They see the trees grow. They look at the fruit trees and they even eat the fruits. It nurtures in them a feeling of well-being on a daily basis. Another NPI that we are using is distraction. It is most frequent intervention used in emergency areas because at that time, the child has just presented into the hospital. Most likely they are in pain. They have come across medical professionals. A particular procedure is going to happen. Maybe the child is already in great pain or discomfort. They are quite anxious. According to recent research, it can lead to reduction in procedure times, a number of staff required from the procedure, and of course, the pain and anxiety experienced by a particular child. So there are different examples of distraction that can be used according to age, developmental stage of a child. Remember that we are supposed to look at both chronological and developmental stage of each child that we are working with. You can come across children who have delayed milestones. They can be older in age, but developmentally they are small children. So this slide will help you to navigate the different examples of distraction tools that we have uniquely tailored to the needs of a particular child. And also remember to use distraction which is appropriate and not in place of an explanation of what to expect. Children thrive on explanation of different procedures or different challenges that they are facing. They lack those discussions. We need to discuss with them age-appropriate language, child-friendly language. They need to understand even before we can distract. let us take our time to explain that particular procedure or explain to a child what they are going through. It could be pain, it could be anxiety, it could be spiritual pain. We talk about it before we can even do the procedure, the distraction, so that it becomes successful. So this moment, I will begin by sharing the different cases that we have experienced on the wards, and then you will be given an opportunity to write on the chat box what you imagine or what you think are the best options of non-pharmacological interventions that we can use uniquely tailored to the particular children on these case studies. So case study number 1, Sarah is a 7-year-old girl who was diagnosed with ALL 6 months ago. She has been undergoing chemotherapy treatment, which has caused significant pain and discomfort. So her clinical presentation, Sarah presents with chemotherapy-induced peripheral neuropathy, resulting in pain and tingling sensations in her hands and feet. She also experiences frequent headaches and generalized body aches, common side effects of her treatment regimen. So looking at Sarah, we are going to give her pharmacological pain management. We are going to give her pain management medications. And in addition to this, we are also going to ensure that we implement an pharmacological intervention to help manage her pain and improve her overall well-being. So what are some of the NPIs that we can use with Sarah? Number 1 could be guided imagery, where we are going to help Sarah to reduce her anxiety and pain perception during chemotherapy sessions. Hypnosis techniques, also called guided imagery and progressive relaxation, tailored to Sarah's age and understanding, can come in quite handy. And according to Sarah, uniquely, she enjoys music therapy. So when she's getting her chemotherapy infusions, she can listen to soothing music. She can be made to choose the kind of music that she wants, and that becomes an outlet for expression. Additionally, we could also use massage therapy so that Sarah can receive gentle massage therapy from her caregiver to alleviate muscle tension that is causing her anxiety and pain to promote circulation. The massages will focus on areas affected by neuropathy and general discomfort. So what are the outcomes for Sarah? After 4 months of integrating NPIs into Sarah's treatment plan, significant improvements were noted. Sarah herself reported reduced pain intensity during massage session or acupuncture. She also reported her headaches and neuropathic symptoms have decreased in frequency and severity. This could be self-report from Sarah, or it could even be reported by her caregiver. And it was also shown that Sarah had improved coping skills. She was less distressed, and this was attributed to moments of guided imagery and music therapy that was given to Sarah. Case number 2. This is Emma, a 14-year-old girl who was diagnosed with chronic kidney disease 2 years ago, which has unfortunately progressed to end-stage renal failure. She undergoes dialysis 3 times a week and is awaiting a kidney transplant. We don't know when this will happen. All the people who can be donors are not compatible with Emma. Despite medical interventions, Emma experiences profound spiritual pain. So we were able to identify challenges experienced by Emma. She displayed anger towards her condition and its impact on her life goals. At 14 years old, Emma is knowledgeable. She's able to use Google Doctor to understand her medical condition. She's able to use WhatsApp and chat with her colleagues in school, with her classmates in school who are continuing with their academics. And so she has a lot of anger. She would like to be a doctor in future. And so she feels that this disease is impacting negatively on her life goals. She feels isolated and has moments of deep sadness about missing out on typical teenage experiences. And she was also questioning her faith and seeking meaning in her suffering. Emma is a mass server in her church. She's a Catholic, and so she has always been very vibrant in her Sunday school, and she continues to serve during Mass. And she has lots of questions to ask God. I've served. I always go to church. Why is this happening to me? So, treatment plan for Emma, we needed to recognize the complexity of Emma's spiritual pain. Because of her age, she was able to really verbalize and even journal in her memory book about her feelings. She was so open. She was so open about her spiritual pain, and she talked on end about how she was missing out on church activities. And so we utilize the following pharmacological interventions: pastoral care and counseling. Being a Catholic, we utilize our hospital chaplain. We have an imam, we have a Catholic priest. We also have Protestant pastors who come to visit the children on their wards. And in Emma's case, the Catholic priest visited her, and she had an opportunity for pastoral counseling. She had an opportunity for the chaplain to talk with her for an entire session, and Emma was able to explain to the priest her need for even receiving a sacrament, which she was given. And Emma finds solace in this session and begins to reconcile her emotions and spiritual beliefs. It is beautiful to see Emma light up when she sees the priest visit her at the bedside. We were also able to introduce art therapy to Emma, and she was able to participate in those sessions, and we could see different themes of hope, resilience, and acceptance through creative expression. So for Emma, art became a therapeutic outlet for processing her spiritual pain and finding inner peace. Additionally, we use mindfulness and meditation. It is important to let Emma know that she's supposed to think about the pain she's facing at this particular moment, the here and now. What is she going through at this moment? Is this anger towards her inability to go to school? Then we provide academic activities for her. Is it anger about her inability to attend Mass? Then we bring in the chaplain to attend to that particular need. So mindfulness is about the here and now. And finally, support groups for Emma. Emma is able to join a support group for teenagers living with chronic illnesses. We have a vibrant oncology and renal support group where they share experiences, they interact with their peers, they also share their challenges over a cup of tea and snack, and it is amazing to see the growth that Emma is currently experiencing. So what are the outcomes that we have seen in Emma? Gradual relief from spiritual distress, and there is emotional resilience. You can observe so much resilience in Emma. And of course, you can see improved relationship between Emma, her healthcare team, her family, which is able to support her holistic well-being. So on this slide, we have shown a picture of spiritual nourishment sessions at the hospital. This is a Sunday service morning session for children. In as much as the children are in the hospital, we give them an opportunity to experience academics, but at the same time, we give them an opportunity to have bonding with a supreme being. If they are Christian, we allow them opportunities for that. If it's a Muslim church, then they can be given an opportunity through the imams that are at the hospital. So spirituality for children with palliative care needs is often discussed in terms of the losses they face relating to their sense of normality. So we have seen that Emma feels inadequate, or she feels a lot of anger because her sense of normality has been has been affected. So spiritual nourishment becomes really crucial, especially for children who are experiencing spiritual pain. So case study number 3, we are going to meet Meshach, who is a 14-year-old, highly verbal child on chemotherapy treatment for leukemia. He always liked being in control and was acutely anxious getting chemo. He would begin vomiting as soon as the chemo started. Anti-nausea medication was not helping at all, and he complained about how it made him feel. He loved riding the bike and was an Arsenal fan who followed the games avidly. He loved reading the sports page on the newspapers provided. I began asking him questions about the Arsenal players and their standing in the Premier League. He proudly showed his prowess by naming all the players and went further to tell me about other teams competing against Arsenal. The talk went on and on and on, and this contained his anxiety sufficiently for his vomiting to reduce dramatically. It was nice to leave behind a tablet with Arsenal games for him to watch as he received the remaining chemotherapy. So for children who are teenagers, we can utilize opportunities for technological distraction. In this slide, we can see the children utilizing a tablet. This is what Meshach was given, and he enjoyed observing or watching the Arsenal game. So guided imagery really works well for such children. So in conclusion, addressing pain in adolescents or in children with different chronic illnesses requires a multidimensional approach that integrates spiritual care, emotional support, and opportunities for creative expression and connection. By tailoring interventions to meet children's unique needs, healthcare providers can enhance quality of life and support in navigating the challenges of medical condition with greater resilience and peace. And so, palliative care teams, typically consisting of doctors, nurses, social workers and child life specialists, chaplains, and other specialists who work together to provide holistic care tailored to the individual needs of the patient and family, is important in alleviating pain, be it spiritual, be it emotional, whatever kind of pain that children with palliative care needs are going through. And I come to the end of my presentation. Thank you so much for listening.
Thank you very much, Elizabeth, for your very, very awesome presentation. We've learned a lot, and I'm sure all of us are inspired to do a lot more for our children with palliative care needs, and even in the acute setup. So I invite everyone to put your questions in the Q&A or to raise your hand so that you can ask questions, and then they're going to be addressed by Elizabeth. So bring your questions, please. Since I see no questions at the moment, maybe I can also ask one as we wait for the other listeners to join us. Is that okay? So,
Yes,
Elizabeth, I wanted to know where now, as healthcare providers, the rest of us can learn more about child life, because it's not like there are schools to learn that in Kenya. If there are, I'm not aware. Or where would one be able to learn more about this?
Okay, thank you, Dr. Marete, for that question. We would still say that child life is still a new profession in the country, since as it is, we are still offering that to in MTRH exclusively. But recently, we've had a training of almost 60 healthcare providers across level 4, 5, and 6 hospitals. So we are focusing on making sure that we can do physical trainings as well as virtual trainings so that we can minister these, minister to as many people as possible to just ensure that we transform healthcare experiences for children. So currently we are working on our curriculum, Dr. Marete, and once this curriculum is completed, then we have identified the Moi Teaching and Referral Hospital College of Health Sciences to be a source of education for anyone who would be interested in accessing a child life training. But for now, we are using the virtual platform mainly. And so when another training comes up, I'm sure you will get to know from the Kehpca platform. Thank you.
Thank you. Somebody is asking whether we are going to have the notes and presentation. This is going to be shared on the Kehpca YouTube channel once it's ready.
Yes, we are going to share the presentations. And also I wanted to add, currently we are also offering both local and international internships. So we have gotten an opportunity to work with child life specialists from across Africa, and we are also receiving Kenyan social workers, anyone who would be interested. It could be counseling psychology, it could be nurses, any kind of people who would be interested to learn more about child life. You're welcome to reach out to me or the hospital for further deliberations. Thank you.
Thank you, Elizabeth. There's a question. That was a very wonderful presentation. Comment on the perception of doctors on the non-pharmacological interventions. What has been your experience with doctors?
Okay, so at the beginning, I spoke about the importance of complementing each other. So at the top there, we are looking at pain medications as being our to-go-to, but we also want to inform us all that non-pharmacological interventions really work well with children. But of course, we have to understand that they have to work in complementary means. At MTRH, we have a lot of support from the medical teams who appreciate what it is we do. So we don't have a problem with the medical teams in MTRH. We work along each other so well, and we support each other because at the end of the day, it's about supporting that child to have as low levels of pain as possible. We are not talking about eradicating pain 100%. I know in some situations we are able, in some situations we are not able, but NPIs come in strongly when we want to focus on mindfulness, the mind of the child. What is the child going through? Is it spiritual pain? There are those pains that you cannot use medication. Then that is where child life specialists will come in strongly with non-pharmacological interventions. Thank you.
Thank you. Tell us about how the parents can be guided to be included in the helping alleviate non-pharmacological pain for children. Some of it was mentioned, but yeah, comment on that.
So we talked about a family-centered care approach and the family being at the center. So we have a number of different support groups for parents in the hospital. We have a neuro support group, renal parent support group, oncology support group, different, even burns unit, be it spina bifida, hydrocephalus. So we put these parents in a particular support group, and in that support group, we start education for massages. We start education for other non-pharmacological interventions. We can meet these parents once a month or even 2 times in a month, depending on the need. For parents who are new and young parents on the unit, we can offer these educations daily, maybe weekly, until we know they have become conversant, and we even observe when they are offering the same interventions to their children. So working closely with caregivers and parents is really key for us, because we know that they are the only ones who can implement these interventions on their children. So we have a number of support groups for parents, which are really have come in handy in supporting children who are in need of non-pharmacological interventions. Thank you.
Thank you very much for the presentation and the questions. I don't see any more questions coming up, but I'm sure everybody can be able to get in touch too with Elizabeth if you have any more questions. So as we finish, if there are no more questions as we finish, we're going to invite Kehpca Executive Director, Mr. David Musioki, to close the meeting for us. Thank you.
Thank you. Thank you all.
Many thanks to everyone. We must acknowledge that it was a great session. Liz, you're the best. A child joked and said, who is that talking like a child? And so being a child specialist, you've become one of the children on a light note. So thank you very much. And Dr. Marete, again, what a great moderator. And the audience, we're grateful for joining in and a great learning session that we had. We continue to host and coordinate this kind of webinars, and we will appreciate continuous engagement with Kehpca, telling us which areas you would wish we get speakers from. Our next webinar coming on the 31st, it will be on spirituality and palliative care, and therefore we'll be sending those updates. We end it at that. Thank you to the Kehpca staff members who work behind the scenes to ensure that these webinars are on. And an announcement that for those who attend for a good amount of time, we have some support for bundles, and they will be sent to you sometimes next week. Thank you. Have a good night and God bless you.
Thank you so much. Bye. Let's go.